Okay, I'm ready on this end. Coming back.
So does that mean I assume that means I start? Okay. So it's my pleasure to introduce today's speaker, Dr. Yama Akbari. So Yama is an associate professor of neurology and neurological surgery. He's a key faculty member here at the Beck and Laser Institute as well. He's recently become division chief of neurocritical care. And he's been an amazing collaborator. He's been just really selfless in terms of what he's been able to contribute to the institute and to to his collaborations and to his lab talks glowingly about him. And I think it's just he does some really cool research. I won't steal any of his thunder here. So just please join me in a warm welcome for Yama.
And colors of the vision pipeline.
Okay, excellent. Okay.
Hi, I'm Jyotsna. I'm a postdoc PhD.
Mhm.
I just joined last July, so my doctoral research was essentially on non-optic microscopy on characterizing nanostructures and some of the collagen. So I'm here to understand more applications in biophotochemistry.
Great, great.
Hi, I'm in my first year of my PhD at WashU. I'm interested in like women's health and wearables, like wearable devices using optics to help diagnose things.
Excellent, great.
Hi, I'm Miller. I am a PhD student at Tulane University, and I'm interested in women's health, and we do photoacoustic imaging in our
What kind of
Photoacoustic.
imaging? Okay, excellent, excellent, great. Yes.
Oh, I'm Sam. I'm a PhD student at WashU, and I'm interested in skin imaging and modeling.
Great, excellent. A lot of WashU, okay.
And I collaborate with Colgate Palmolive to do oral health research.
Oral health. Interesting, okay. Great, yeah.
I'm Kiki. I'm a third-year PhD. I'm also at WashU. And I do my work's on a laser speckle wearable.
Excellent. For what
So
application?
we do women's health as well. So I'm measuring blood flow for postpartum hemorrhage detection.
Interesting. Postpartum hemorrhage detection, brain hemorrhage, or what kind of hemorrhage?
Oh,
Oh,
sorry,
sorry.
fetus.
Okay, gotcha. I thought you meant the fetus because there's a lot of fetal
Oh, yeah.
hemorrhage as well. So,
It's from
okay, excellent.
Hi, my name is Yama. I'm a master's student also at WashU. My focus is on square imaging for bruises and inflammation, as well as low cost
Okay.
devices.
Great, cool. Yes. you can go ahead too, Bernard.
My name is Hector, and I have been working mainly in the past in near-infrared spectroscopy applied to brain hemodynamics. I've been working in the numerical modeling aspect of some experiments on phantoms and equal that exponential analysis. Now I shifted a little bit to something more focused on fluorescence. So I am using fluorescence to determine the hypoxia status in the context of cancer, and also to detect like critical normal structures such as nerves and vascular bundles in the context of laparoscopic surgery.
So from not, you went from brain to like laparoscopic,
Yeah.
everything, a lot of work. I mean, where are you from?
So I am from Argentina. Right now I'm working in Dartmouth,
Where's that?
Dartmouth College.
Okay, Dartmouth. Yeah, gotcha. Great. Okay. Yes.
Hi, I'm Brian. I'm a rising third year PhD student at UT Austin. Currently I'm building like a microscope for Raman and fluorescence microscope for non-melanoma skin cancer, like surgical guidance, specifically for Mohs micrographic surgery.
Excellent. Great.
I'm Najib. I'm from Polytechnic Montreal. I work on surgical using Raman spectroscopy for surgical guidance also, but like probe-based technique.
Gotcha. Excellent. Great.
Hi, I'm Helena. I'm a PhD student at Rice University, and I'm working on multimodal imaging for cervical cancer.
Great. Excellent.
I'm Anna. I'm also a PhD student at Boston University, and I'm working on a laser spectral wearable as well, but for cuffless blood pressure, ambulatory blood pressure monitoring.
You're from Rice also?
Boston University.
Boston University. Okay. Okay. Well, a lot of WashU, a lot of women's health. I'll try my best to connect with everybody. Yes. Wait, did I miss you?
Yes, I'm Scott. I'm not a PhD student.
Good.
I've lost interest in everything. I'm currently working on a laser device to treat dry eye.
Dry eye.
Mhm.
Excellent. Okay, cool. A lot of a wide, diverse audience. So I have a lot of slides, but I wasn't sure. I always pack a lot of slides because I don't know how to connect best. But now that I know, I can I'll skip through a lot of these slides. So don't be scared about these. These are just some disclosures, some of our funding agencies. We have some IP, several with Bernard Choi. A couple have been issued and sponsored and all that. So this is just to give you guys an idea of why I do what I do, and hopefully it'll connect with all the interests that you guys have. But just to show you a little bit of the motivational aspects of me, what's something that all these people have in common? Aside from being famous. What's that? That's right. Yeah, most of them died. Couple, he's alive. Bronny James, right? I hope. And then Hamlin, this guy. But they all had a cardiac arrest actually at some point. So that's kind of what I deal with. Is the matter of life or death. And I'll just kind of briefly go through some other motivational aspects of why I do what I do. But this was when I was an intern. I saw this kid, 25 years old. He's probably, I shouldn't say kid because he's probably the same age as some of you, but half my age. At the time, I was around his age. But he ended up coming. I saw him in the emergency room. He had an medication overdose. We couldn't save him. He went into a coma. We had to do cardiac arrest. I was like a month after medical school. We ended up doing a code blue on him, a CPR and all these things. And he died. Like, we couldn't do anything. For 30 minutes, tried to do CPR on this guy. He was an only kid. He was an only child from his parents. His parents were immigrants. And they were like, save our child, and it was kind of traumatic for me. I wasn't used to that. And so that really kind of got me motivated why we can't save people when they're in this kind of state. It's the most critical care of the field of critical care. It's the matter of life or death. So I deal with this, unfortunately. Somebody's got to do it. So that's why, oh, thank you. Awesome. Thank you. Awesome. Thank you so much. Yeah. So anyway, I just want to let you guys know this is why I'm so motivated to do this, and we work hard, and I'm thankful to collaborate with Bernard and Vasan, and they kind of see the vision on what I do. So if I sound a little crazy and a little too interested in this, it's because this is important. Not everybody has a stroke. Not everybody has a melanoma. Not everybody has a women's health problem or a traumatic brain injury or anything, or cancer, but everybody is going to suffer from cardiac arrest. All of you, me, everybody is going to have this. And most of the time it's unexpected and it's too early. Sometimes we deal with people that are very old and they're like, I've had a good life, let me go. and we have to respect that. But most of the time, we code patients. We do CPR on them, and a lot of times we fail. So this is something that's very close to my heart, so that you guys, appreciate this aspect, because some of the research is focused on that. And I think if we can understand this better, we can understand a lot of things better, because it kind of incorporates many of your interests as well. This slide is to highlight why multimodal monitoring became interesting to me. This was, just a few years ago when I was a faculty, actually, where I had this patient, 7 years old. He was on life support. He had a melanoma, and so we see a lot of melanoma. When it metastasizes to the brain, it becomes our patient. And so he had a lot of seizures because of the metastases. And so he went into status epilepticus. So we put him in a medically induced coma. We completely flatlined him on his brain activity. And we had him on a continuous EEG. And I remember vividly, this was right around the time, right before I think I met Bernard. It was early in my faculty career. But the wife grabbed me when I was walking on the hallway, and she said, my husband looks so pale. And I'm like, well, everybody looks pale. I look pale sometimes too. But I went in there and I realized I couldn't feel a pulse on him. And I'm like, he does look pale. He doesn't have a pulse. But I look up at the monitor. I'm like, everything looks fine. This is weird. So we escorted the patient out, and I recycled the blood pressure cuff, and it was not readable. So I realized this guy's in cardiac arrest. Because sometimes it's hard to feel a pulse sometimes on some patients if they have atherosclerotic disease. Or calcification, but he was in cardiac arrest. So we ended up doing CPR on him. We brought him back. We pushed the medication actually really quickly. His blood pressure cuff recycled. It was very low blood pressure, so that validated that he was indeed in cardiac arrest. And if we felt the pulse come back, and we rescued him, he came back. But this was like frustrating to him. Like, how can somebody die in the ICU? Like, they're on monitoring. That's why you're in the ICU. But I mean, as you probably already figured, the problem here is that we just had a non-invasive blood pressure cuff, right? You can't recycle it every minute. I mean, if you guys all get your blood pressure checked, it's frustrating. It's not comfortable. You can't keep doing that every minute or every 2 minutes. So we typically recycle it every 15 minutes, every 30 minutes, every hour if they're very stable. In this patient, it was every 15 minutes. So had we put in an invasive arterial line, this would never have happened. But you can't put an invasive catheter into everybody. And we're good at that. We put catheters everywhere in the body, pretty much every single major artery, in catheters into the brain. We're really good at doing that. But these are all invasive, and they're not without risks. So the idea for this is the type of experience that I have, and I have these still, I still have these kinds of experiences, is to develop better monitoring and non-invasive monitoring. So we don't have to like drill holes in people's heads and put catheters everywhere that can lead to infection, bleeding, complications. A simple arterial line, you can lead to an amputation in the entire arm if you damage it and it becomes ischemic. And I have met people who are missing an arm because of an arterial. So we can't put an arterial line into everybody, even though it's a simple procedure. And so you guys all probably already understand cardiac arrest. Christian, one of Bernard's prior graduate students and current project scientists, made this slide. But normally, the heart is beating pretty well. I think I lost the animation on the slide here. But cardiac arrest happens, everything stops. We do CPR. We're very good at bringing the patients back. In the hospital, we have a very high success rate, like 60, 70, 80% success rate, sometimes 90%. The heart regains function. We're good at that. But the problem is just the brain. The brain is way too sensitive. And so just even a couple of minutes of anoxia or lack of blood can lead to permanent damage. And so what I focus on with cardiac arrest is simply, definition is just failure of the heart pumping forward. And that can be due to any of these organs failing. It can be due to the heart failing, the lungs failing, circulation failing, or the brain failing. So if you have a heart attack, right, with the standard typical cause of cardiac arrest due to coronary artery disease, that's common. But a lot of times people have cardiac arrhythmias, young people, babies, kids, or Bronny James, athletes have this a lot, or congenital heart disease. And usually when this happens, they're shockable rhythms, so we shock them out of it. We do CPR. People can choke. Obviously, I see a lot of choking victims. The Heimlich maneuver fails, they end up having respiratory failure. And then because of the respiratory failure, the heart stops. We end up having to initiate CPR on them. This time of the season, we see a lot of drowning victims. Malcolm Jamal Warner, I think is the last name, but I grew up watching this guy on the Cosby Show. I just met somebody last night who knew him, or my wife, I should say, met this lady who knew him, and it's a small world. Everybody's connected somehow, but he drowned in the riptide in Costa Rica. So he's like one of the actors on the Cosby Show. Probably you guys are a little too young for the Cosby Show, but anybody can drown. It can happen to anybody. And so we see a lot of people, good swimmers, sometimes drown. And when that happens, same thing. Respiratory failure leads to, we have to do cardiac arrest. Drug overdose is huge. So another huge unmet clinical need where people, regular people, get tolerant to opioids. They require a lot of it to treat their pain conditions. And the side consequence, the side effect is respiratory depression. And they stop breathing. And they don't even know they stop breathing. And so they sleep, they take some pills, they sleep, they stop breathing. If you catch them really promptly, you can give a Narcan, an opioid antagonist. But a lot of times it's not given early enough, and it is a short-acting drug. So one injection or one inhaler is not sufficient. You have to keep giving it to them. And then that leads to respiratory failure, CPR. But septic shock is another way that cardiac arrest can happen. The brain failing means basically neurogenic shock. We see patients with traumatic brain injury, severe spinal injury. They end up in cardiac arrest as well. ICD sometimes. Young people, huge impact, traumatic brain injury or high-level cervical injury, their heart stops immediately. No bleeding, nothing. So there's a lot of ways that we see patients, and sometimes it's not easy to figure out. So we have to fix the heart and then figure out what caused the cardiac arrest, any of these things. But when we do this, we focus on airway, breathing, circulation, or usually in the order of circulation, airway, breathing. We do basic life support, CPR, and advanced cardiac life support. But that's kind of like, just so that you guys see, we see a lot of diverse people. So the unmet clinical needs are huge. And so it's huge. If you combine all of these types of cardiac arrests, over 1 million, a quarter of them between in-hospital and out of hospital can be resuscitated usually, but a very small fraction of them end up normal. There's always a deficit, whether it's a little bit of your IQ lost or eternal coma forever that you don't wake up. And so, we always want to know how can we not only resuscitate their heart, but protect their brain at this time. And so I'll skip through that slide, but basically time is brain. I think to demonstrate how important this is, when I say every second counts, really every second counts. And to put things into perspective, when I was in college, before I started my MD PhD program, stroke, the newest treatment for stroke came out, which is clot busting medications, which we use frequently now, very frequently, every day. But now the window for stroke treatment has gone up to 24 hours, which is incredible. At the time when it got FDA approved around 1995, the clot busting medications were given within 3 hours. But now we've increased that to 4.5 to 6 hours, but then we can pull out the clot, which is called a thrombectomy, up to 24 hours after. It's incredible, meaning we're doing pretty good for stroke treatment. But when we talk about not a focal ischemic here, but the entire body being ischemia, which is global, we call it a global stroke, you don't have 24 hours. You don't have 6 hours. You don't have 3 hours. You have like 2 minutes to start. Otherwise, it's like gone. You know what I mean? 5 minutes, 10 minutes is damaging, very damaging to the brain. So that's why we have a very high sense of urgency for this. These are all the types of patients that I see, not just we get consulted on every single cardiac arrest in the hospital, but we see a lot of stroke, hemorrhage, spinal cord injury, a lot of aneurysm ruptures and trauma, hematomas and traumatic brain injury. So anybody like this can come to our unit. You don't have to have a big lesion like this, even if it's a small brain problem. Then my job is to regulate the whole body to support the brain. And that's why I have to be able to understand the heart, the lungs, the kidneys, the liver, all that. We can't call specialists like for all this stuff. We will obviously call them if it's beyond our capacity to help us. But my job is tough, and I'm always learning, and I'm always humbled because the body is complex, and the brain is really complex. And it's so sensitive that every organ just messing up just a little bit can screw up your brain. And to be able to protect the brain, we need to have monitoring. And so our patients are a lot of times are on a lot of life support, a bunch of monitors. We monitor the brain through various different means. That's just a stock photo. We have newer devices than what's shown there. But the brain, when you have a heart attack, you have chest pain. You're like, my heart hurts. Like I have some chest pain. When you have a stroke, it's hard to say, I'm having a stroke, help me out. So we have to have, especially when our patients are comatose. Now they can't even complain about chest pain. So we just have to put a lot of monitors on them so that they have a voice. So, the brain is by far the most sensitive organ. It makes us who we are. Pretty much all major organs can be transplanted. Heart, lungs, kidneys, liver, part of your pancreas, certainly skin, cornea, many different parts. And as longevity increases, I think that the problem is going to be the brain, because we'll probably be able to protect or replace a lot of these organs, but dementia is eventually going to get to us. And so in the neuro ICU, it makes our job hard. It's very challenging. So I'll focus on like some primary and secondary brain injuries, but primary is just what they came up with, why they came to the hospital. Was it trauma, stroke, or hemorrhage? But the secondary injury is what we really can make a difference on. We don't focus on the past, we don't focus on the future, we focus on the present. And the present is what we're doing now is we're avoiding hypoperfusion, right? Low blood flow to a region, brain and other organs as well. We're focusing on avoiding low oxygen level, hypoxemia. We're focusing on avoiding reperfusion injury. These are things that we have a lot of control over, but oftentimes we don't know when and how to regulate these things. And so whenever we have patients that have even a single episode of hypotension, of low blood pressure, it can double the mortality. If they have a couple of episodes, 1 or 2 episodes of hypoxemia, it can triple the mortality. In intracranial pressure, that studies show that if there's a sustained elevation in your intracranial pressure, even for 5 minutes, it can significantly worsen morbidity and mortality. So we're basically on the defense. We're getting more now on the offensive region, but a lot of times we're protecting rather than acting. But this is a good time because now we're getting more on the offensive. So how do we monitor our patients in the ICU setting? You guys are all familiar with simple pulse oximeters, cardiac telemetry, blood pressure cuff, simple ICU monitors. That's typical. Every place has that. But the problem is when you have a comatose patient, you need a lot of brain monitoring. And so we have a lot of patients in a coma, and the coma is defined by somebody who lacks both arousal, which is wakefulness, and awareness. So everybody's awake here, hopefully. By the end of the talk, maybe a little bit less aroused, but if you have both arousal and awareness, then you're not in a coma, you're normal. If you lack wakefulness or awareness, then you get at that next level down. And so we have a spectrum. If you lack both of them, you're in a coma. If you are sometimes awake and sometimes aware, you're in this minimally conscious state. And if you're awake, but you're not aware, that's called a vegetative state. We have a lot of these kinds of patients as well. They're in la-la land. Our patients, about half of our patients are in a coma at some point or another. And in other ICUs, like the medical ICU, surgical ICU, about a quarter of the patients are in a coma. And coma in and of itself is actually an independent predictor of death and the length of stay in the ICU. The problem is so many different things cause a coma, so it's a little bit hard to study. And so that's why neuromonitoring is very critical for our patients. So how do we monitor our patients? Well, believe it or not, even in this day and age, we literally have to examine the patients every hour. That might seem ridiculous to you, but that's the best we can do. It's kind of crazy. I forgot to put an image, a slide that I typically show, but typically I made this ChatGPT generated image where basically I wanted the ideal patient, and it generated this image of this person with all these monitors all over, and it was cool. I'm like, that's what we need. And if we had that, we wouldn't have to wake up our patients every hour. But we do. That's what we do. So every hour we wake them up. We like talk to them, see if they're awake. We try to wake them up. We pause sedation. We shine light in their eye and pinch them, literally, pinch them to see. We check their reflexes. We see how deep their coma is using this Glasgow coma scale. We use what's called a pupillometer, which is just a light. It just shines light and it quantitates how fast and how the responses, the pupillary constriction responses, using an algorithm, which is very accurate. It's really helpful. And then the next 55 minutes, they go unmonitored. It's like they might herniate, they might like completely screw up, and they could have a stroke, which is scary. But you can't keep examining them every 5 minutes. Sure, we can put them on EEG, continuous EEG. Everybody's familiar with EEG here, right? If I say anything that you guys don't understand, feel free to raise your hand. Don't be shy. Sometimes I take things for granted, but we do put a lot of patients on EEG. It's not perfect by any means. It helps a little bit, but you can't do that on every single patient. Certainly not, smaller hospitals. Imaging takes time. By imaging, I mean static imaging. Common things in hospitals: CAT scan, CT of the head, MRI. These are just one-time thing. But our patients are also on a lot of life support. Like moving them with a lot of stuff is very risky. It is not fun to code patients in the elevator. It's very scary when they're in the hallway and their blood pressure crashes. So we limit transporting them if we don't have to. So again, we go back to bedside monitors, so we don't have to transport them all the time. And even when we have CAT scans like this was actually two of my patients. I from a while back, they were literally next door to each other. They both, these CAT scans, if you guys agree, kind of look similar to each other, right? It doesn't look that different. There's a little white spot here in the brainstem area, but you know what? One of these patients has a GCS of 15, which is the maximum score, meaning they're fully awake, moving everything is perfect. This one is in the lowest. GCS 3 is the lowest in the scale. Completely in a coma on no sedation. So clearly imaging is not extremely helpful at times, and it can actually lead you in the wrong direction. This kind of imaging, at least, which is the most common. So what do we do to monitor our patients, like in these days, aside from standard EEG, other types of algorithms that are very common, BIS monitors, or Satellite device by Massimo, starting a lot of ICP monitors. Lycox is an oxygenation monitor. These are all invasive. We have to drill a hole in the head and put it inside them. But we're focusing more on non-invasive imaging modalities. This is a patient of ours that we drilled a hole in the head and put a catheter in. We did put in a ventriculostomy, and using a manometer system, we can extract fluid if it exceeds a certain pressure. We can put other devices inside that hole as well, but minimally invasive, still invasive. You can lead to complications. This is what we focus on a lot. That is relevant to you guys. A lot of optics. I put this picture up because this is a company that Bernard and I know of from several years ago. It's been almost 10 years now, 8 to 10 years, but it's a company called Ornan. They used optics as well as ultrasound to use, so they use light and ultrasound to basically estimate brain oxygenation and to protect the brain. It was a great idea. Their data looked wonderful. Their patents looked excellent. Their publications, but when they tried to commercialize this, it was a total failure, despite raising $100 million and being widely used at several places, including UCI. within a year or two, they folded because it was a failure in mechanical properties. The way they designed that was very poor for many, many reasons. The signal to noise ratio was not good. The comfort level for patients was horrible. The artifact level during certain maneuvers and certain sort of things that we do in the ICU was just a disaster. The nurses hated it, and it was just horrible. So still good technology, but a complete failure of commercialization. That has happened with other companies as well, and that just goes to show that it's not just about the science. It's about actually when you go from science, great discovery, to commercialization, there are a lot of other complicated steps to do to make sure that you are able to eventually take it to the bedside, make a difference, and help patients out. So I'll just focus on cerebral blood flow and brain metabolism, a little bit on brain electrical activity on some of this talk. But there are a lot of ways to measure cerebral blood flow. CT angiography, certainly. We have transcranial Doppler ultrasound. Conventional angiography, which is basically taking a catheter, putting it in the femoral artery, driving the catheter up, and using fluoroscopy, squirting dye. We do that a lot as well. Very accurate, but invasive, certainly. PET scans, SPECT scans, MR. We do a lot of MR. Thermodilution techniques, quantitative EEG. This is just in a couple of groups that are transplanting one animal's head on another animal, and actually can keep as long as you keep blood flow going in, and connect the carotid arteries and the vertebral, the bath arteries, you can actually keep a brain alive for quite a long time. These are things that we can control. We can actually modify blood flow very well using medications, ventilator adjustments. We can do a lot. It's like we have a lot of power. Believe me, we have a lot of stuff. The problem is that we don't know when and how to do it because we need feedback to tell us if we're doing the right thing or not. An example of this, I'm just going to come up on one of these slides. Yeah. So I'll show you in a couple of slides. But the problem is that the first problem is we need non-invasive devices. We need continuous devices, preferably high speed. We need bedside portable devices, and it has to be reliable, accurate, and valid. And so like this is one device that we use a lot. Bernard and Vasan and I, we collaborate a lot using time-resolved spectroscopy that we'll talk about a little bit in more detail later. We used to use this pocket NIRS device. They work extremely well, especially time-resolved spectroscopy. It's phenomenal. But this is an example of a project that our lab and Bernard's lab, we worked on this, but we basically, this is from many years ago. This is an example of how if a doctor tells you they know what they're doing, make sure they know what they're doing. This is a time when I thought I knew what I was doing, where we gave epinephrine, and of course epinephrine increases your blood pressure. So here, this is an animal that's being monitored with laser speckle imaging that we'll talk about. You guys are going to learn a lot about laser speckle imaging, right? They haven't learned a lot about LSI and SFDI yet. Yeah, so you'll become experts in it by next week. But this is the blood pressure. We gave epinephrine, and the blood pressure went way up, which is expected, and then it goes down, which is expected. It's great, right? If somebody's having a stroke, you would give epinephrine to them, right? You increase the blood pressure, you save them, right? That's great. Well, the blue is the cerebral blood flow in this animal. The cerebral blood flow went down. Okay, not good. All right. So when I saw this, I'm like, oh my God, I've been doing it wrong all this time. Well, this was a unique animal because of various circumstances. It doesn't always do this, but sometimes it does this for various reasons. So sometimes what you think you're doing to help somebody is actually harmful to them. In this case, it was harmful for the patient because we don't really care about the blood pressure in this animal, which is being measured in the femoral artery or the arm, whatever. This is more important. This is more important than your arm or your leg. And so this is a patient that Bill Mantulin and Bruce Tromberg and from Beckman Laser Institute did many years ago. Same thing. they gave this patient some vasopressors, two different vasopressors, ephedrine and phenylephrine, which increased the mean arterial pressure as expected. But the cardiac output was widely different between these two, and therefore the brain oxygen saturation went down with this one. So this one had a higher blood pressure rise, but it actually worsened the brain oxygenation. So again, this is a clinical grade example of sometimes what we think we're doing is right, it's incorrect because the brain is complicated and we don't have monitoring systems for it. And so we're taught that one size fits all. It's not true. I always try to teach our residents and medical students and clinical fellows that we have to tailor things, where this is definitely the era of precision medicine and things have to be tailored. If your blood pressure is typically 110 and your blood pressure typically is 140, right? 140 for you would be very high, right? 110 for you would be low. So we can't treat everybody the same. So we need a lot of data and evidence to know what is baseline for somebody. And we don't do that now. So wearable sensors, if we have long-term data, can help for this. If you give me a data sheet and I'm like, oh yeah, your blood pressure over the past month was 110 and you know, God forbid you're in the ICU, I'm like, I know how to treat you well. And likewise for you. But we don't have that kind of data. So the wearable sensors, I think, are going to help us a lot in the future. But we're trying to make sure we do precision medicine. So in our lab, we get a lot of information in our ICU. We raise these questions. We have an animal ICU next door here. You're welcome to come if you ever want to see that. In the future, if you ever want them to take a tour of the neuro ICU, if they ever time, like it might be hard for this, but in the future, happy to coordinate with you on that. But we bring these questions, we raise them, we bring them back to our animal ICU. We do a lot of signal processing. We look at all the ex vivo effects on the organs. We save all the organs from head to toe because a lot of times we do cardiac arrest experiments, and then we basically go back to the ICU. So we have a nice bench to bedside flow on things where we're doing clinical research, device development. And so we developed an animal ICU. It kind of looks like this. I mean, this is a picture of it, but without all the cannulations and all the surgeries, but it's on a ventilator. We have access, vascular access. We have several ventilators in the lab. We get, you know, a pen like this. This is all modifiable however we want, but we get brain information up here, electrocorticography, AC and DC channels. We get continuous blood pressure, like this animal's is 132 over 81, and it's, you know, nice waveform, EKG, EMG. We can add a lot of things to this with 32 channels that we can fill up. We have non-invasive pulse oximetry and blood pressure as well. We have an arterial blood gas monitor. Within 2 minutes with a drop of blood, we can get all the hemoglobin, full oxygen levels, you know, whatever you want. There's different cartridges. You can get cardiac troponins, you can get liver enzymes, you can get all this within 1 or 2 minutes. And we get a lot of information from our animals. The system we developed with Bernard and Bruce Tromberg's lab 10 years now, I can't believe it's been 10 years now, is a combination of laser speckle imaging. This is custom built. This was originally built by Mo, right, by Mohammed, right, way back when with Christian, and then Rob Wilson helped with some of the analyses, and Tin's been helping us unbelievably recently. Thank you very much, Tin. So basically, laser speckle imaging, which allows us to obtain cerebral blood flow, and spatial frequency domain imaging, which allows us to assess oxy and deoxyhemoglobin. I'll talk a little bit more about that in the subsequent slides. But putting all this together allows us to really get both blood flow and metabolism, or blood flow, oxygenation, and when we combine those, we can get a continuous measure of metabolism, cerebral metabolic rate of oxygen, and we can shift it from the brain, from the cerebral, to anywhere else if we want to measure the metabolic rate on the skin, anywhere else as well. And we've even done open chest experiments where we can actually get it, because this is high speed, we can measure changes in the lungs, We can measure changes in the heart as long as it's a non-contact system. It just doesn't penetrate deep, and I'll talk a little bit more about that later. So it's a very powerful system where you can get a lot of wonderful information. The SFDI that we use, which generates square wave spatial patterns, we have different frequencies. For the LEDs, those can be changed, but these are specifically to measure oxy and deoxy hemoglobin. You guys are probably, some of you are probably experts in this, and if not, you will be experts by the end of this week and next week. But we measure the absorption of light in various tissues, focusing on the brain. And so I fell in love with optics. Bernard and Bruce Tromberg got me to fall in love with this because it was when I started learning about it, I'm like, wow, you can really measure anything. Everything has a fingerprint for absorption. Here it's just showing when oxygen is bound to hemoglobin, so oxyhemoglobin, this is the type of absorption spectrum it has. If it's unbound, if it's deoxyhemoglobin, this is the type of absorption that it has. And if it's something else like water, this is the type of absorption spectrum. Lipid has a different, so by understanding the properties that these molecules have, you can choose what you want to study. And so the spatial frequency domain imaging system that we have, we are focused on specific wavelengths of light that allow us to get information on the amount of oxy and deoxyhemoglobin. And we can extend this with some of our clinical grade equipment, our time resolved spectroscopy. We have an additional wavelengths where we can actually focus on lipid and water. And so, you can measure really anything. And that's why it's beautiful, it's powerful, and you can use all the different optical tools. This is just one. And we'll talk about that a little bit later as well. So this is an example of an experiment that we did. You're going to see this animal die, so it's dead right here, okay? Completely dark. And we resuscitated the animal, and it came back, and this is called hyperperfusion. So this is the blood pressure, cerebral blood flow. This is the oxygen saturation. This is the EEG. You can see when the animal died, the EEG went flat, okay? EEG goes flat, meaning you're in a coma. There's no detectable electrocorticography activity, at least in the superficial cortex. But clinically, we call this dead. It is reversible because you can bring back the heart, and we do here. And then you see this characteristic pattern. So despite the blood pressure coming back, the blood flow having these characteristic fluctuations, the EEG takes a while to start igniting. So this is the animal's in a very big coma here, and it remains in a coma even though the bursting sort of happens here for a good 2, 3, 4 hours. It remains in a coma, very similar to our patients. So yes, yeah. By the next day, it's pretty good. It's not normal. Even after 3, 4 days, if you do more advanced quantitative EEG, it's not 100% normal. If you just look at the raw EEG, it's hard to tell because the amplitude is the same, everything. But then when you do some analysis on it, the spectrograms look a little different. The connectivity is different, so the coherence, they're a little bit different. So, and that's a great question. If we get an animal that's like 2 days or 3 days or 1 day, and we just look at the quantitative EEG, for example, we can tell how long it's been after cardiac. It's like an MRI. Like an MRI can tell us when a stroke happened. If it's 1 day old, 3 days old, a week old, this is very similar to that. Yeah. This is just for anybody who likes waveform analysis. This makes me like a kid in a candy store because it's amazing, in my opinion, to see that with all of this occurring here, the only thing we control is the ventilation, the green here, because we set the ventilator, right? So each of these going up is the machine breathing for it, okay? And close-up here is every time the ventilator goes off, you can see that there's a tiny rise in the intracranial pressure. So what we do in the lungs affects the brain. This is the blood pressure. We don't have cerebral blood flow on this one, on this slide here, but the blood pressure is ongoing like this. The cerebral blood flow also has fluctuations like this. The ECOG, the brain electrical activity here, you can't see because it's zoomed in, but if you come back here, this is a burst, right? And then like, 10, 20 seconds later, there's another burst, okay? Or whatever that is, five seconds later, another burst. You can see every time the brain activity bursts, there's a massive rise in the intracranial pressure. That's huge. So this is called neurovascular coupling. Every time the brain has a burst, it's commanding more blood flow, and the blood flow comes in, it increases the cerebral intracranial pressure. There's small changes here, but they can be huge and massive. And so this is just, and that changes before cardiac arrest. So CA is not California, but cardiac arrest, and post cardiac arrest, okay? They change, and so even the wave patterns change. So by understanding this kind of stuff in our patients, we really can do quite a bit for our patients. We don't do any of this in our patients right now. This is an animal, but the first time I saw this data, I'm like, my gosh, it's incredible how much power we have, because in this study, it's actually prognostic. How the wave patterns change predicts the animal the next day. And if we had this kind of information, it would be amazing. And so right now, this is where we're at. So pre-California, cardiac arrest, post-cardiac arrest. We're in this area. When we get a patient, it's like, all we do is like cool the patient down, therapeutic hypothermia, we augment their blood pressure a little bit, we protect them from seizures, and then we're like, oh, we did our job. Well, I think that's bullshit, excuse my language, but because it's like too late, way too late, and we're kind of patting ourselves on the head and doing a great job. We're not doing a great job. It's far too late and ineffective. And so we're interested in not only providing neuroprotection before cardiac arrest, but what happens during cardiac arrest, consciousness, how it's lost, looking at these things that I'll mention a little bit on brain tsunamis, hemodynamics. What is happening as we're dying and we're dead, we're clinically dead? And more importantly, what can we do during CPR to really aggressively bring these patients back through treatments during CPR and the minutes after? And that's where we make the biggest difference. And some of the work that Bernard's lab and I have done have shown very clearly these are critical moments. And that's where if we can bring that to the bench side, it will save a lot of lives. But unfortunately, it's right now it's too little, too late. And that's what makes me frustrated. And so for the interest of time, let me just kind of skip through some of these. Okay, these are just some spreading the polarizations that I don't want to bore you guys too much on. But suffice it to say that through signal processing, we can discover, we notice a lot of weird things happening as the animal's dying, and that we can capture these through optics, through scattering, for example. And you can see some of these occurring through light. And that's what's really fascinating, I think, in that these waves predict recovery the next day as they're happening. And if we can do this, if we can use light to capture these things as a patient's dying or as we're bringing them back, it will impact how we make prognoses of the patient and how we treat them later on. That's really the key. Even after we resuscitate the patient, there are these waves that are captured using scattering. And so a lot of times scattering, people don't focus on scattering. Well, maybe I used to not focus on scattering, but when I saw these, I started appreciating that everything, not just absorption is important, but the scattering is really important. And so, so we can detect vasoconstriction, which is very important in our model. We know that different types of cardiac arrest have different characteristics of some of these waves that we see, which is very important because a lot of times when you get patients, we don't know what type of cardiac arrest they had. And if we miss the moment of cardiac arrest, we can actually detect changes within the minute after resuscitation. So another window of opportunity. And so we're in the line of, okay, if we miss the cardiac arrest, we can maybe do something during CPR. If we miss CPR, even after, like a minute or two after, we can follow some of the wave patterns. We can have a ratio such as cerebral blood flow over cerebral metabolic rate of oxygen. And actually, within a minute, the good and the bad animals, depending on how much brain damage they had, start separating, which allows us a prognosis that correlates with much later on, even up to the next day. And so some of these prediction algorithms diminish. Within 3 minutes, they're gone. It's like you have 2 minutes to capture that data, or it's gone. And so in the hospital setting, we use a lot of these devices. We use a lot of other investigational devices, some of which were developed by several faculty on campus here, such as Michelle Kine. Some of those are not optics, but then we have Bernard's lab that developed this FlowMet device that got a couple of his prior grad students developed it, had a startup, got bought out by Medtronic. But optics can be used for a lot of things. These are all commercially available now as well. These are spatial frequency domain imaging on the bottom, Tony Durkin's lab. So we use a lot of these. This is one of the devices that we use, time resolved spectroscopy. This is a 5 wavelength system that I mentioned to you earlier. And using the smaller wavelengths, we can detect changes in oxy and deoxyhemoglobin. The larger, longer wavelengths can detect the water in the lipid. And so it has, this one has one light source with 2 detectors on both sides. And then we have another one that has 2 separate sources with 2 separate detectors as well. This one has 3 wavelengths, and we've been able to apply this during strokes as the patients are actually having a stroke and they're in the fluoroscopy suite, the interventional radiology suite. And that's very important because that can help guide us in real time what to do to a patient. And so within the interventional radiology suite, they come in. We actually had a patient today that came in with an acute stroke. We captured it, and then it requires really fast, application of this device. And for some of these we need consent. For some of them we can have waiver of consent. And so I'll just skip through some of this because I know we're running short on time. But basically, this is a patient. That a 66-year-old male who came in with a stroke. And we ended up pulling the clot out. That's called a mechanical thrombectomy. And Vasan and I have been collaborating on this very closely for the past year or two. And what we're noticing is that as the clot is being pulled out, you can see changes on this device. In real time, you can actually see the changes occurring, which is incredible. It actually can tell us whether the patient, when the clot is pulled out, and whether the tissue there is dead or not, is basically. We're just about to submit this paper, which I think is going to be phenomenal. It's highly accurate. And so why is that important? Because if you pull out a clot and you know the patient, the tissue there is dead, there's no other way to know at that moment that the tissue is dead. You have to do an MRI, which is going to take a day or two. But I, as an intensive care doctor, I need to know whether the tissue is dead or not. I'm not going to push the blood pressure up and all that if it's dead tissue because there's complications involved. So if we have a device like this, it's going to affect not only that moment when the interventional neurologists and interventional endovascular surgeons are pulling the clot out. Should they keep going at it if they can't pull the whole thing out? Not only is it going to affect their judgment, but my judgment for the next entire day or two until an MRI is done. We also applied this device to subarachnoid hemorrhage patients, which is basically like an aneurysm rupturing. And these patients typically get something called a vasospasm always. And that, if you survive the aneurysm rupture, you end up, the next most common cause of morbidity and mortality is this vasospasm. It's probably due to inflammation, happens several days later. They're like, fine, fine, fine. You know, they have an aneurysm rupture. They're like, fine. You know, maybe they're on a ventilator and things like that. And then all of a sudden, like a week later, boom, they get this weird vasospasm response, and they can die from this. And I've seen a lot of patients die from that vasospasm. And there's really little we can do other than, number one, detect it, which is hard. Number two, start trying to vasodilate those vessels. So we augment their blood pressure. Remember that epinephrine slide I told you? Well, clearly blood pressure is not, we need a direct blood flow to make sure we're not worsening it, number one. And number two, we drive a catheter up and we actually we put a balloon catheter and we actually inflate the balloon catheter to do an angioplasty in the brain to try to prevent the stroke. The problem is, how do you detect it on time? It could happen at 2 a.m., right? So we need neuromonitoring. And we did another study where we enrolled about 25 of these patients, and remarkably, it's quite accurate. Number one, we can detect it, vasospasm, and number two, during the angioplasty, we can actually see changes on our monitor. Like this patient here, who had vasospasm, got a verapamil, which is a vasodilator, it's a calcium channel blocker, and the moment it was injected, you can see a big difference here that goes. This is the other side that did not get injected. So this is all being injected on the right side here, and it sustained higher. So we can see real-time changes, which is huge. It's like immediate feedback. This is another patient that had the same. There's another patient that had the same. So it's really, really highly accurate in terms. So this is a separate project that we've done that's pretty accurate. This is actually showing after they get angioplasty, our device can actually correlate with the standard of care currently, which is ultrasound, which is transcranial Doppler ultrasound. But you can only do ultrasound like one time a day. You can't keep doing it, right? It's really, if anybody is familiar with transcranial Doppler, you gotta like hold it up. It's like really like operator dependent. Like I suck at it. And like if you just go like this, it's like different. So it has to be the same person, same exact spot, and then you get accurate. But time resolved spectroscopy correlates quite well with it, where we can actually see changes in continuously, more importantly, continuously, whereas TCDs are done once in a while. This is another patient of ours that you can detect changes. This little break here is the moment of angioplasty, where you inflate the balloon, and you can see changes significantly at that moment that are occurring. So it's remarkable that these changes are happening. Just skip through some of this. So we can detect changes in stroke. These are some of the correlations. And then this is part of a major project that Vasan and I have been working on, our lab and our lab members, is multi-layer analysis, because two of the major limitations with at least time resolved spectroscopy and any kind of optics and neuro-optics is the layers, right? The skull is thick, there's the skin, there's multiple layers involved here within the skull, within the skin, within the skull, and underneath the skull, the meninges, that the light has to penetrate. And so there are a lot of limitations in absorption and scattering going in and coming out through the detector. And that's one. And the other thing is the curvature of the skull. Those are big limitations that Vasan is helping us with his expert area that you guys are learning more on. And so one of these successful projects that Vasan and I are working on is that we're looking at patient-specific anatomy. How do we get this more specific, right? So we look at the CAT scans. Everybody gets a CAT scan, so that's not a problem. Every single, they walk in the ER, you're gonna get irradiated like crazy and get a CAT scan. So we can have a three-dimensional image, basically, of a patient's skull and brain, and we can get that. We use the idea is to get the patient-specific anatomy, develop an optical model of the different layers, incorporate the photon counts in time, and then get patient-specific physiology, so that every single data set we get, we're going to make it patient-specific. If we can do that, this gets to precision medicine, and it's going to really improve the accuracy, reliability of this. Even without that, we're getting really good significance. But if we can develop this, it's going to take us to a different level. And so I don't want to pretend like I'm the expert in this, because the expert's sitting right there. So he can talk and educate you guys, and I'm sure you guys have some of the courses. I think today you guys learned about Monte Carlo simulations, and so that's what Vasan's expertise is, and it's been a delight to collaborate with him and learn from him. But you know, in our model, using our techniques between the source and detector, there's so many different layers that it has to go through, and each layer ends up adding a level of complexity to it. And so the diffusion models are oftentimes too simple, and the Monte Carlo simulations, as you guys are learning, they're a little slow for real time. They're very good. They're accurate and wonderful. They're a little bit slower. Although Vasan's working on faster systems now for us, and that's important, because you need, in what I do, you need stuff in real time. This is not a clinic like, we're going to get data, come back in 3 months, and we'll check on you and give you the data. No, we need stuff now, or the patient's going to die. So we have to work on improving things to develop a really fast model that approximates all the heterogeneous geometries. And so this is a slide that Michael Helton, who worked with Vasan, developed, where the one layer model, a 2-layer model, and then comparing that to a Monte Carlo model. So diffusion theory models with Monte Carlo models, quite similar, and showing that the 2-layer model is much more similar to a Monte Carlo model. That can be, if it can be developed, especially if we can make it a little bit faster. So this is just the multi-layer model, but taking the curvature into account will get us to the next level higher. And so you guys are probably learning a lot about this, if not already in the next few days. But most of this, I should have probably put this a little earlier, but the focus is on diffuse optics. That's kind of what we do in the patients, at least, and in our lab here. But the dynamic model that we do for the superficial layers, we use laser speckle imaging. That's what we do very well in the lab, in our animal model. But for the deep layers, we have to shift to diffuse correlation spectroscopy. We are getting a device, speckle contrast optical spectroscopy, that is somewhat, a variation of this, but that is gonna, so we're gonna be able to measure cerebral blood flow in our patients in the deep tissue. We're really excited about that. We're getting basically a alpha model. The full model is going to come out in a few months, but we got a final code on that a few days ago. So we're really excited about that. So we're going to have this ability in our patients. We have this ability thanks to Bernard and all of his work here in our lab. And this is obviously being done in skin, so everybody, in patients, but it's hard to do in humans unless the skull is off, because you got to penetrate through. So in the operating room, you can use this, but not really if your skull is intact. The static diffuse optics divided up into superficial and deep. So spatial frequency domain imaging is also a superficial technique, doesn't penetrate too deep, perfect for our animal models here and perfect for skin in humans. But again, can't go through the skull. You have to have the skull off. So to be able to image deep, then we use diffuse optical spectroscopy or time resolved spectroscopy, like what I showed you, or the standard kind of, commonly commercially available continuous wave nears. Those all can have somewhat, deep. But the idea is to be able to have both deep and superficial tools to be able to, and dynamic and static, and combine these. And so as most of you already know, with continuous wave nears, which is the status quo right now, still 90% or 95% of the market is using continuous wave nears, which has been around for decades. That just assumes that the light scattering is constant. But as I showed a few slides ago, right? Remember the scattering goes up in those, some of those waves that I showed you when our animals are. So scattering is important. We don't want to keep it constant. We want to measure scattering. And so to do that, then we would need to move to these other techniques, such as time resolved spectroscopy and SFDI and frequency domain. Those allow us to measure scattering. And so we use this table. This was put together by Rob Warren, who did his PhD here with Bruce Tromberg. But do you need a non-contact? Do you want high resolution imaging? Do you want to measure STO2 and hemoglobin, water? Do you want deep scattering? Do you want non-invasive? And by doing this, you can kind of pick and choose which one you want. And this is what's like, I feel like a kid in a candy store when I have this. Obviously, we need to develop these a lot better, but it's really incredible. Even since this slide was made, you know, we have probes now for some of these where we can direct it. It doesn't have to be only in the front of the head. Hair is always a limitation, but to be honest with you, in my line of field, we shave people's heads, and yes, there's follicles, but sometimes it's not a big limitation. It's not the biggest limitation, so we can shift around. And so we just want to revolutionize the field and be able to monitor the brain and the heart and the lungs. It's about the interconnections between the organs, and we have these portable devices. And so with the last few slides, I just want to shift. I just want to kind of broaden your perspective, because this looks complicated, but to put it in a nutshell, most of what I've talked about so far is about diagnostics. But what we're now entering is the age of therapeutics, using all these modalities. And so in the old days, and still now, sure, we have a lot of medications, but now we're getting into using all these different modalities, including light, to modulate the brain. So electromagnetic stimulation is very common now. We have devices here at UCI also, transcranial direct stimulation, transcranial magnetic stimulation, focused ultrasound. These modulate the brain. Photobiomodulation is something that I'm very interested in. Red light therapy is very common now. It's been tested, and you probably see it on like YouTube videos where you wear something and then it it makes you like focus better or something like that. Some of those may need more data for, but there are ways to modulate the brain. So we're really getting in this age where we can do so much, and a lot of these techniques can be used in some of your areas of interest, whether it's women's health or skin, to be able to modulate things. But the idea is to make everything smaller. We do use a lot of. Now we've been using FDA-approved devices off-label for other things. Like this is a device that we have in the lab. It's a vagus nerve stimulator. And you literally just hold it right here and just zap right there. Because the vagus nerve is the longest nerve in your body. It connects your brain to all your other organs, including women's health areas, including the heart, including the lungs, including the liver, everything, the gut. The gut is huge. The brain, so the brain connects to all these organs using the vagus nerve, and there is a way to stimulate the vagus nerve. And so we tested this in our animals here, and we know that every time we stimulate, actually you get a transient rise in the cerebral blood flow, and then you get a sustained rise if you do it again. And if you keep stimulating, you actually have changes in your, so you can actually have induced neuromodulation. It's bidirectional. When you stimulate here, it goes down and it travels up, but we can use this off-label. That's one of the points I just want to make, is that these devices are available. They just haven't been used for other purposes. Like VNS, vagus nerve stimulation, is used. It's FDA approved for migraine, for depression, for seizures, but it can be used for a lot of things. But we need monitors to be able to tell us what we're doing. We have all these tools. Here's another device. I think you might be interested in something like this, but this is a device that's FDA approved for hemorrhagic shock. It's very easy to put in. It's a little catheter. We just drive it up to the aorta. We inflate the balloon. What that enables us is all the blood that's pumped down actually now can't go down, so you get twice as much blood to go up to your heart and lungs. Very powerful, and it's FDA approved for hemorrhagic shock, meaning if somebody gets stabbed somewhere that's non-compressible. If that happens, you're going to bleed to death. You can't compress the site. So you can give them some blood and all that stuff, but they're going to hemorrhage to death rapidly. And so this was approved because you can stick this in here as long as whichever side is intact. You can stick it in there. You just inflate the balloon, no more blood, no more bleeding. And then you calmly take the patient, give them some blood, take the patient to the operating room, and fix the wound. So we use this now to augment blood flow in the brain. And so we have in our animal model, we've done this. And so you can see it here, we inflate, and that's the aorta, and it inflates, and now blood cannot go down. It bounces back and it perfuses the brain. And so you can see the blood pressure here. When I inflate this, it doubles, which is incredible. In like 3 seconds, it went from like 100 to 200. So boom, we can do this. But remember that figure I showed you about epinephrine decreasing the blood flow. This doesn't do that. This increases cerebral blood flow. So it circumvents all those problems. But the only way to do that is to have monitoring for the brain. So we have all these tools. We just we don't have a target. We're not getting feedback on it. But on this study, we actually did really well. I'll just skip through some of these. We were able to actually save animals. We were able to reduce epinephrine need, all of this. And the animals did extremely well when we gave this. And we're moving to doing ECMO now as well. Well, we're just about to order does anybody know extracorporeal membrane oxygenation? It's basically a heart-lung machine. You can stop the heart, lungs, just the thing oxygenates and perfuses your entire body. And so we do that on our patients sometimes. So we're having an animal model as well, because it's very important. These patients sometimes don't do well. Part of it is because we don't understand the brain. People think, oh, if you just put blood flow into the brain, the whole body's getting, no, but the brain is very sensitive. It's very sensitive. So if we don't have monitors for the brain, we don't know how to put the settings on ECMO. And it's also missing pulsatility. And so nobody monitors the brain on ECMO. But we're now getting into that phase where we can monitor the brain. And we're also developing a pig model to do everything that I mentioned to you, a pig model, because sometimes it's hard to go from a mouse to a human without a large animal model. And so we're in the process of doing this. And in fact, that device I mentioned earlier, the SCOS device, spectral contrast optical spectroscopy, we're going to actually apply it to the pigs. Pigs have a thick head, but their anatomy is actually quite similar to humans. We do a lot of other things. We have rapid EEG system. We've done over 100 patients. And then we have a lot of clinical trials where we're using some of these use optics in multiple sites. Let's see. This is one of my patients that survived, but that's pretty much it. Yeah, happy to take any questions. Hopefully I've shown you a little bit about optics and how it's used and why we use it, the unmet clinical needs, mostly in diagnostics, but hopefully in therapeutic ranges as well. Yeah, thank you all.
Questions for Yama?
Hi. So when you showed the absorption spectra, you showed like 4 wavelengths.
Mhm.
Do you know why those wavelengths were chosen?
So it depends. For our purpose, if we're looking at oxy and deoxyhemoglobin, studies show that those are some of the best wavelengths where you can actually categorize oxyhemoglobin and deoxyhemoglobin. But Bernard and Tin could probably explain. I mean, there are a lot of different wavelengths that can be used that may have some advantages depending on maybe the acidity, the composition of the environment that the hemoglobin molecule is in, where the absorption may change. But getting that, I mean, feel free to chime in. But typically in historical studies, those are the standard wavelengths that are used, plus or minus a few nanometers.
Okay, that's actually probably somewhat of the inverse problem. So what it is you measure reflectance.
Thank you.
At several wavelengths, which correspond to different absorption coefficient, those curves. And then we go back to solving essentially a system linear equation. And the idea is that you want to choose the coefficient that are unique enough for that system of equation to be fully defined. And that's why those specific wavelengths are chosen. And it definitely depends on the chromophores, the absorbers, in this case, hemoglobin and deoxyhemoglobin that you're looking into. We're going to get into that sometime next week, I think. Some of the labs actually talked about if you choose the wrong wavelength, what would happen, or not wrong, but like if you choose a less sensitive wavelength, what would happen? So good question, though.
Yama's talk to some extent was a good preview for next week. A lot of the technology that he was talking about, the ones that we're going to cover.
So this brings a lot of memories to me. I feel nostalgic now. Thank you for that. So I think at some point you said you would explain how you can measure oxy and deoxyhemoglobin. So I think the idea is to use like two wavelengths or maybe, yeah. Okay, okay. No spoilers then. Yeah, I guess. Then do you measure absolute values of these concentrations, or do you measure like changes relative to a baseline, or?
That's a great question,
Okay.
and the course may actually talk about that more. But to answer your question, yes, we with time resolved spectroscopy, that's one of the major advantages is that we get absolute values.
Yeah.
But we have another commercially available device in our ICU that I use a lot now. It's built by Massimo. It's called an O3 monitor. That gives us typical continuous wave NIRS. It's not time resolved spectroscopy.
Okay.
That just gives us relative changes.
Mhm.
And that you ask a very important question because a lot of our work shows that the absolute values are important, but the relative changes are also important.
Yeah.
And so sometimes you want both. But the question is, if a patient comes in and I want a rapid information, I don't have time to look for relative changes. I need something absolute right there.
Mhm.
You know, because the change already occurred.
Yep.
You know, if I put it on and I'm inducing a change, sure, the relative change is important, but the absolute value is very important as well. The other reason it's important is because a lot of times there's something called autonomic dysregulation in our patients. And that just means that like normal people, if there's a change in one system, there's another change in a compensatory change in another system. And when there's injury, wherever it is, the brain, you know, obstetrics, gynecologic regions, the skin, you know, the heart, lungs, that system gets completely messed up. And so the compensation is lacking. And so with that, then the question comes, how do we test for that? Because it's very hard to test that. And so even in there, the relative changes are sometimes confounded by the injury. So whereas if it's the absolute measurements are there, that affects the relative changes. So for example, if your absolute change is high, let's say your absolute level is high and something like that, maybe it's already saturated.
Yeah.
So you won't get a big relative change. But if your absolute value is low, maybe you'll still get a relative change because there's a lot of saturation problems in our systems. And I always teach people, like anything saturated is bad. Like pulse oximetry sucks because when you're like 100%,
Yeah.
I don't know what that means. You know what I mean?
Yeah, you see, and if I can ask another question. So I'm particularly interested in the layer models that you mentioned before. And I like the comparison that you do with the two-layer Monte Carlo data and the homogeneous model, right? Which doesn't really replicate what happens with the Monte Carlo simulation. And then you use the two-layer model and that much better the situation.
Yes.
And I think the two-layer model is a good way to separate, let's say, the cerebral tissue and the extracerebral
That's
tissue.
right.
But then you also showed that we can think of the head as a stack of
Yes.
layers. So what happens when you have like more than two layers?
That's a great question.
yeah.
The expert's standing right there, but,
Okay.
but we're starting small is the goal. If
Okay.
we can understand 2-layer, then we can get to 3-layer or 4-layer.
Okay.
Yeah.
Good. Thank you.
I can comment, but maybe we can do that later if there are other questions, because we've got the clinician here and only he can answer certain questions.
I was just gonna ask a clinical question about ECMO.
So how do you determine if someone can be placed on ECMO? And then my second question to that is,
how do you envision using the technology to help patients that are on ECMO, like the monitoring technology?
So if a patient's heart is failing or a patient's lung is failing and we cannot compensate with it through our traditional methods of life support, such as a ventilator, right? Because with a ventilator, you need to you deliver oxygen, you remove carbon dioxide, but that assumes that the lungs can take that oxygen and carbon dioxide and transmit it to the blood vessels. So if you have messed up lungs, you can deliver all the oxygen and all of it's not getting absorbed. You need basically you need a lung transplant, right? Or let the time for the lungs to heal if it's healable. So in that sense, you need an extracorporeal method of oxygenation. So that's lung failing. If your heart is failing, like literally you have a massive heart attack and you're on a bunch of medications that's whacking your heart, these vasopressors, epinephrine and dopamine, and you're just like, but the heart is so messed up that even that is not sufficient. They're going to die. So you need an extracorporeal way of perfusing the brain. So anytime the lung is failing or the heart is failing, you need to be able to do that. Like dialysis is to clean out when the kidneys are failing, right? And if the heart and lungs are failing, you need ECMO basically. So we put patients on ECMO sometimes because of that, to buy them time basically, because you can't remain on ECMO for a long time. But then you ask the next question, which is important. How do you optimize ECMO? So there are some settings on ECMO, how much perfusion is going, how much oxygen is being delivered, how much carbon dioxide is being taken out. The way we put those settings is suboptimal, if that's your question. We look at arterial blood gas, we look at their blood pressure, when we measure it. But again, this is not what we're trying to save. The oxygen, we're trying to save the brain. The brain is the most sensitive of the whole. And so that's why one of our collaborations, the picture with the Reboa catheter, I had a picture of a person on the top left. He's a pediatric surgeon. He puts a lot of little kids on ECMO. And that collaboration actually started because of your question. He called me up. I didn't know who he was. He said, yeah, you do cardiac rescue. He said, I put these kids on ECMO and I can keep them perfectly fine on ECMO, oxygen level perfect, blood pressure is fine, everything, because I take them out and they don't wake up. And it's like something happened to the brain. They didn't have a brain problem. They had a heart problem. Now they got a brain problem. Thanks a lot, Well, so what do we do? So that's why hopefully that I was able to convey that one of the key things is to be able to monitor the brain. And if we can monitor the brain, we'll be able to set those settings to make sure that the perfusion and oxygenation in the brain is optimal. That's what we're lacking. Is that helpful? You're welcome.
Struggles here, Brian, so one thing I will say to kind of sum up is, hopefully, I assume that probably very few people here before Yama spoke gave much thought to how their research or how what they're doing has any relevance to cardiac arrest, CPR. And so one of the things, not to say that that's the sort of thing that you should be looking at in your research, but there are natural links to the stuff that you guys are developing, focusing on as a PhD.
Yeah, no
There's a
problem.
whole plethora of different applications for these. So hopefully,
Yeah, not too.
established reputation. Kind of gave one example of how some of the technology you're working on, and you can start working, you might have to work on something completely different. Maybe also, I don't know whenever you thought you'd be doing modeling the brain.
Yeah, that's right.
I never did the other long time start working on the brain as well. Scott done thrombolysis years ago.